everyone. Good morning, Program Director, faculty members, and delegates. Um, I'm Dr. Suyash Sharma, and thank you from Zydus Medical Team. We are grateful to our organizers to let us be a part of today's meeting. So over to you. I'll hand over the session to Dr. Amit. Over to you, sir.
Thank you so much, Dr. Suyash. Very good morning to all of you, and good afternoon and good evening to all others who are joining from rest part of the world. Today, our guest speaker for the day is our own professor, Dr. Maitri Bhattacharya, and she's going to lecture on approach to bleeding disorders. This webinar is brought to you by Mumbai Hematology Group, supported by Zydus, dedicated to life, and very well managed by Perfect Square. I thank Mr. Ashish Kumar, Mr. Sumit Madan and the team Zydus, Mr. Yash, Mr. Kalpesh and the team Perfect Square, Executive Committee of Mumbai Hematology Group, our chief guest for the day, Professor Naveen Kakkar from Himachal Pradesh, our guest speaker for the day, Professor Maitri Bhattacharya from Kolkata, all our discussants who are themselves eminent hematologists, and you participants for sparing the Sunday morning, afternoon and evening. Next Saturday, that is 2nd September 2023 from 7 p.m. onwards, we have a webinar on current approach to risk stratification and management of frontline CLL by our guest speaker, Dr. Samir Parekh from Mayo Clinic, Rochester, Minnesota, USA. And the following day, that is 3rd September 2023 Sunday, we have a webinar on individualized treatment of Hodgkin's lymphoma from 11:30 a.m. onwards, IST, and 8 a.m. onwards, German time, by our guest speaker, Dr. Paul J. Brockelmann from University Hospital of Cologne, Germany. Let me introduce our discussions for the day, and we have a galaxy of them here displayed in alphabetical order. To start with, we have Dr. A.K. Ganju from American Oncology Institute, Nagpur, Dr. Abhishek Ranjan from Center for Blood Disorders, Lalpur, Ranchi, Dr. Akshay Manloy from TMH HBCH, Varanasi, Dr. Avinash Kumar Singh from Paras HMRI Hospital and Patna Hematology Clinic, Patna, Bihar, Dr. Devdutt Basu from Jipmar, Pondicherry, Dr. Gunjan Loni from Wockhardt Hospitals, Nagpur, Dr. Karuna Kumar from Yashoda Hospital, Secunderabad, Dr. Ketan Modak from National Cancer Institute, Nagpur, Dr. Kunal Chatani from Nagpur, Dr. Kunal Goyal from Tata Memorial Hospital, Varanasi, Dr. Neha Gunju from Ganju Hematology Clinic and Hospital, Nagpur, Dr. Nilesh Vasekar from Nashik Hematology Services and Ashoka Medical Hospital, Nashik, Dr. Nishad Dakate from HCG NCHRI Cancer Center, Nagpur, Dr. Pritesh Junagade from Oncology and Bone Marrow Transplantation Center, Lotus Institute of Hematology, Nasik, Dr. Riya Balikar from Wockhardt Hospitals, Nagpur, Dr. Siddesh Kalantri from Blood Care Hematology Clinic, Nasik, Dr. Sudarshan Pandit from Blood Plus Hematology Center and Ashoka Medicover Hospital, Nasik, Dr. Varun Bafna from Dr. Bafna's Star Clinic and Hospital, Kolhapur, Dr. Vinod Patil from Onco Life Care Cancer Center and Rudhir Hematology Center, Satara, Dr. Vishwadip Kushu from AIMS, Nagpur. Now it's a time to introduce our special guest for the day. We have with us our chief guest, Dr. Naveen Kakkar from Himachal Pradesh. Dr. Naveen Kakkar is Professor, Department of Pathology from Maharishi Barkandeshwar Medical College and Hospital, Kamarhati, Solan, Himachal Pradesh. He did his MBBS followed by MD in Pathology from Christian Medical College and Hospital, Ludhiana. His interest is in automated hematology analyzer, coagulation disorders, hemoglobin disorders, hemolytic anemias, leukemias, and software development for hematology reporting. He has over 91 publications in peer-reviewed, reputed international and national journals. It's my privilege to welcome him to inaugurate our webinar and give some words of wisdom. Over to you, Professor Dr. Naveen Kakkar.
Thank you, Dr. Amit. I'm not sure if I'm experienced enough or knowledgeable enough to do this, but Dr. M.B. Agarwal requested me, so here I am. And this is for our younger colleagues. So if we remember our medical student times when we were interns or postgraduate students, the first thing on rounds that the consultant usually asked after the initial assessment of the patient was, what's the CBC for today? So it's one of the most common investigations of blood that we see. Hematology is a unique system It's liquid, goes everywhere. So there is no specialty left untouched, as you notice. So you'll get consults from pediatrics, medicine, surgery, and all over. An orthopedician wanting to operate a patient who has hemophilia will obviously come to you. And like we know, there are many disorders, benign and malignant, that touch the patient's lives and allow doctors to come in and treat it for them. So it's a multidisciplinary system, and you will get consults or queries from all over. It's important to find mentors in real life. And my mentor in CMC, when I was working in CMC Ludhiana, was Dr. Britt. He was a retired consultant from Hillingdon Hospital, UK. He used to visit our hospital for 1 to 2 months. And in those days, when we ran manual testing for CBC, he got us a gifted, discarded Beckman Coulter counter from the US. That was a square, big box which ran on pneumatic pumps, unlike the electrovalves. So it made a lot of noises of hisses and sounds of the pumps working. And he prepared his own reagents. I remember him adding thiazide crystals to stop the growth of fungus in those crystals in the humid atmosphere. And the way he wanted to run the analyzers made me inspired to see more into this world. And later on, as we went on in our career in hematology, Dr. Maman Chandri, Dr. Sukesh, Dr. M.B. Agarwal himself, I remember the Bombay hospital meetings that played a major role in us getting our eyes open to what is happening new in hematology. And in hematology, there are a limited number of cells. We are lucky, although in histopathology also there are limited, but the way they are, I think histopathology for me was a tough one to begin with. It's a long learning curve. Hematology, I feel, gives you independence early. If you can sort out these limited number of cells, maybe 5 to 7 in the peripheral blood, 10 to 15 in the bone marrow, master this morphology well, and remember there are gray areas in between. So we see some classical cells like the book describes, and in everyday life we see lots of shades of gray. So if you work on your morphology well and sort it out, it gives you a lot of confidence to sort even the automation later. There's one thing I want to emphasize for the youngsters. We often hear with the postgraduate students sometimes that there were 2 cells that I couldn't make out, which I left from the DLC. And I always teach my postgraduate students, one day will come when there will be a slide which will have all of these cells that you ignored. So it's important to chase this cell and find out what is the possible cell, ask somebody else who has more experience, send an image to somebody. But working on morphology, I think, is the basis, even though automation has come a long way. It's easy to get into this trap of being office consultants, sitting in the office, ordering a test, the slide coming to you and interpreting. I want all the postgraduate students, even interns who work or have an interest in lab hematology later on, go to the lab, dirty your hands, stay on your own slides, do a PT test, do a mixing study yourself. The knowledge that you get with the troubleshooting is unmatched. No book can teach you that. So if your hands are not dirty at the end of your training period, you've lost it. So, and even maybe an SR, then you're afraid to ask because I should have learned this earlier. Can I ask this question? But again, keep questioning. It doesn't matter how senior you go in the hierarchy rung, keep questioning. That'll help. When we look at hematology beyond morphology, we have analyzers, automated analyzers, coagulometers, we have flow cytometers, molecular testing. So the avenues are expanding. So you can get a flavor of everything early on and then say, I want to do this specifically and go into that. It's a lot of intellectual challenging questions that come to you every day. And it helps when we sort it out for the clinician, and building that rapport is very important. Otherwise, the lab and the clinicians usually do not go hand in hand. So there are limited centers where there is good cooperation and understanding of each other. So it's important for us to understand the pressures a clinician works on, and then they will understand the gray areas that we go through. Why do we need more time? Why are we asking for more blood? Why are we rejecting some samples? So that rapport is very, very essential, I feel. But today's topic, which is coagulation, is again one of the most ignored topics across India. And if you look at your undergraduate teaching, you'll probably not remember your coagulation class. If you go to postgraduate, everybody's focused on nutritional anemias, bone marrows, leukemias, flow cytometry. The PT, APTT, mixing study somehow gets ignored still. And the answer is because there is nothing to see. So in hematology, otherwise for a slide, bone marrow, you have cells to see, cells to count, interpret. In coagulation, what do we have? A liquid plasma, you add a liquid reagent, it gels up a bit, and that's it. So, but the challenges in coagulation that you may face, and if you are understanding that pathway well, as Dr. Maitri will tell us today, you will actually be able to sort out most problems. Another thing, when we talk about coagulation, everybody is thinking hemophilia first. Remember, the acquired causes are much more prevalent and a day-to-day problem for most clinicians. Most general physicians are not able to work out even simple coagulation problems. So where the lab needs to come in, educate, interact, and go with that. So looking at mentorship, getting your hands dirty is my mantra for the youngsters. And I won't take much time for Dr. Mathri. Over to you.
Thank you, Professor Dr. Naveen Kakkar, for that wonderful words of wisdom. And it will be a much benefit to our youngsters. Whatever you said is a big benefit to our youngsters and all the residents. Thank you for being with this today, Sunday morning.
Thank you.
Let me share the screen again. Now is the time to introduce our guest speaker for the day, Professor Dr. Maitri Bhattacharya. Professor Dr. Maitri Bhattacharya is DM in Clinical Hematology from AIIMS, Director at Institute of Hematology and Transfusion Medicine, IHTM, Medical College, Kolkata, Honorary Secretary at Indian Society of Hematology and Blood Transfusion. She is the first DM hematologist from Eastern India and has over 25 years of experience in hematology. She also honors in biochemistry. She received her membership from Scientific Advisory Committee, SAC, National Institute of Immunohematology, Mumbai. She is a reviewer of various journals like Indian Journal of Hematology and Blood Transfusion, Clinical Chemistry and Laboratory Medicine, Indian Journal of Pathology and Microbiology, and others. She was the first to start BMT in state government hospital in West Bengal. Having interest in research work and writing, she has several publications in peer-reviewed national and international journals. She has written over 15 books on various aspects of hematology. Her membership and activities include, to name a few, member of Scientific Advisory Committee, SSC, National Institute of Immunohematology, Mumbai, advisory board member of Bengal Medical Genomics Center, advisory board member of MRU, that is IPG MER Kolkata, nodal officer of MRU Medical College, nodal officer for hemoglobinopathy and hemophilia control program in West Bengal. She is reviewer of various journals, to name a few again, reviewer of ISHBT Journal, reviewer of Indian Journal of Public Health, reviewer of Indian Journal of Pathology and Microbiology, reviewer of Indian Journal of Medical Research, International Journal of Hemoglobin, Journal of Clinical Chemistry and Lab Medicine, Nature, Laboratory Hematology, as well as she is a reviewer of hemoglobin. She has been examiner for DM Clinical Hematology for various medical colleges like AIIMS, Delhi, CMC Vellore. She has been also examiner of DNB Hematology. She has been PhD examiner for Calcutta University, University of Health Sciences, Kolkata, and AIIMS, New Delhi. Her orations include Srimanta Chatterjee Oration for Thalassemia and Obstetrics, Journey Towards a Better Now, J.B. Chatterjee Memorial Oration, Thalassemia in West Bengal, K.P. Das Memorial Oration, Hemoglobin E Syndromes, J.B. Chatterjee Oration, STM, Hemoglobin E Beta Thalassemia, Phenotypic Diversity. Today, she is going to lecture us on approach to bleeding disorders. Well, thank you so much. Over to you, Professor Dr. Maitri Bhattacharya, ma'am.
Very good morning to you all. And I thank the Professor M.B. Agarwal for inviting me for giving this talk, and also at the same time for choosing a subject like approach to bleeding disorder. As Dr. Kakkar said, that this is a problem which is faced not only by the hematologist, by pediatrician, obstetrician, and physician, even surgeons. Everybody face this problem challenge in their day-to-day practice. And to me, if you ask me, coagulation is the most difficult part of hematology. So this should be very clear to all of us. So before going to the topic of disorder, let's first recapitulate the hemostatic problem system in our body, how it works. It consists of vascular endothelium, platelets, coagulation factors, fibrinolytic system, coagulation inhibitors. So, and by this, the whole system works. So whenever there is a breach in the endothelium, you can see this platelet goes to that side and forms a platelet plaque. This platelet plaque actually activates the coagulation factors which are present in inactivated form in the plasma. So this coagulation factors forms a fibrin mesh. You can see the network here, but this is a very ugly network of fibrin mesh. And then the fibrinolytic system comes into play, remove the excess part of the fibrin mesh and shapes the coagulation, the clot. Once this coagulation is activated, it will go on. So there should be a check in the body to stop the coagulation also. So before going how it stops, let's recapitulate again what are the factors and how it acts to form the clot. So in our MBBS days, it was said that it consists of two pathways, intrinsic and extrinsic pathway. But now all of us know that it starts with tissue factor and factor 7. Then it goes here, then it activates 9 to 9A, then 10, 5, 2, and ultimately a small amount of fibrin clot is formed. So this pathway is not enough to control any bleeding. This thrombin clot, actually this thrombin goes here and activates this pathway, and by this pathway there is generation of robust amount of clot. So this is what happens whenever there is injury or bleeding, and these are the factors which stops the bleeding. So what are the factors which controls or stops the bleeding? These are the anticoagulant mechanism. Most important is antithrombin. This is the major inhibitor of coagulation cascade. It inhibits thrombin and also inhibits other factors also. This action of antithrombin is enhanced by heparin. Tissue factor pathway, I told you that the coagulation starts from tissue factor only. So this tissue factor pathway is inhibited by 3-FPI, tissue factor pathway inhibitor. So that way also coagulation is controlled and it's stopped. Protein C and proteinase, all of us know. So whenever there is thrombin, this activates along with thrombomodulin, protein C. Protein C works along with proteinase, and these actually degrades many coagulation factor and stop the coagulation. So this is the background we have. Now, whenever any patient comes to us with a complaint of bleeding, first and foremost thing, as is a case of MBBS days, as you all know, like every case is basically a MBBS case. If you are a good MBBS student, then you are a good DM student also. So first and foremost thing is a history and physical examination we need to do. And from this, if we suspect that there is underlying bleeding disorder, of course, we will have to go for the screening test. So this is a patient of 17 years old boy who has suddenly gum bleeding, and you can see there are appearance of certain papillary spots over the body. And this is another case of young, very, very little boy, 7 months old male child who developed swelling over the right thigh. You can see the swelling. This developed 24 hours after intramuscular injection given as a part of immunization. The child was very irritable, not moving the right leg, and swelling of this site was warm and tender also. So I show you two pictures. One is there is for papillary spots over the arm and over the body, and there is a swelling and some sort of hematoma over the thigh of a small child followed by injury. So whenever any bleeding occurs, as I have shown you, the coagulation system predominantly consists of platelets and coagulation defect. So it may be bleeding, maybe either defect of platelet. This defect may be a quantitative defect, thrombocytopenia, or maybe a qualitative defect. Platelet may be normal in number, but they may not be functionally active. And or it may be a defect in the coagulation pathway. It may be congenital, or it may be even acquired one also. So how, whenever a patient comes to us with a bleeding manifestation, first and foremost thing is to that from the history and examination, we'll have to decide whether this bleeding is a platelet type bleeding or a coagulation type bleeding, because our further approach or investigations will depend on that. So in case of platelet type bleeding, onset is immediate. In case of coagulation factor bleeding, it defects. As I've shown you, the small kid developed the swelling in the thumb, swelling in the thigh after 24 hours after the intramuscular injection. This is mainly petechial spots, and there is hematoma involving the muscle. This is most commonly platelet type bleed occurs in the mucosal membrane only. Skin and mucosa are mainly involved. Here it's not common, it's commonly in the deep muscles and the joints. So Here there are other complications of pseudotumors also, but predominantly what we should remember is that if the bleeding is a mucocutaneous type, then it's most like a platelet type bleeding. If the bleeding is a musculoskeletal or joint involved, then it's most likely a coagulation factor bleeding. And if it's a delayed onset, then also a coagulation factor defect is expected. Another thing is that in platelet type bleeding, if you press over the side, it's easy to control the bleeding. But in case of coagulation factor bleeding, it's difficult even with pressure to control the bleeding whenever it's because of coagulation factor defect. So what are the histories and generally clinical examinations we should do whenever a patient has come to us with bleeding manifestations? First and most important is site of bleeding, age of onset, because that will guide you whether it's a congenital thing or an acquired one. Precipitating factor is important. If it's unprovoked without any precipitating factor, then means it's a severe type of disorder. Bleeding occurring spontaneously. Drug history, many of the drugs can cause coagulation factor functional defect and even a platelet functional defect. Associated symptoms like fever, joint pain, this suggests that it may be secondary to primary disease. So there may be some other disease because of that the patient is having this bleeding problem. And history of hospitalization, blood transfusion, this suggests that the bleeding is a severe one. How it's controlled, as I told you, with pressure, with medicine, with they will tell you with blood transfusion, with white blood transfusion, that means with plasma transfusion. So that history also is important, and family history again, which suggests that this is a familial or an inherited one and congenital one. Examination will have to rule out other problems like jaundice, which suggests that there may be a hepatocellular problems also, organomegaly, and most important to find out whether there is wet purpura, because if it's present, then you are dealing with a serious case and you will have to treat immediately to control that. So what are the salient points about bleeding? Most common bleeding of platelet disorders are epistaxis and gum bleeding. In female, it may be menorrhagia. But what I want to mention is that hematuria is rare, unless in case of hemophilia, sometimes patient comes with hematuria. Hemoptysis almost never occur because of underlying bleeding disorder. Same is hematemesis unless there is a gastritis or gastric erosions, or if there is a varices. So in most of these cases, if hemoptysis, hematemesis, will have to think first that it may be because of local pathology, not maybe because of any coagulation or platelet defect. So many a times patient comes to us that complain that they are having menorrhagia, and otherwise also whenever we are taking history of a bleeding disorder, we ask the patients that whether she is having menorrhagia or not, and it's very difficult because it's a subjective one, so you don't know. It's difficult to predict whether actually menorrhagia is there or not. So this is more common in platelet type of disorder and von Willebrand disease. So how we can guess if the heavy flow is more than 3 days, total duration more than 7 days, total amount of blood loss more than 80 ml, this is very difficult to judge, but the duration of flow you can judge. Passage of large clots, size more than 1 inch. So this suggests, and if she requests a change of pad every hour. So these are some of the questions we can ask to judge whether the patient is having really menorrhagia or not. So as I told you, there are 2 types of bleeding. This is mucocutaneous bleeding, cutaneous and mucous membrane. And these are the bleeding in the joints and the muscles. So depending on these, the underlying factor also, underlying disease also will vary. So there is a scoring system of International Society of Thrombosis and Hemostasis. So this is the bleeding assessment tool or BAT. So with these, every thing has been given 4 points. And with this, we can judge whether there are 14 points. How severe is the bleeding? So clinically, whenever the patient has come to you asking this, you can judge whether this patient, how severe is the patient's problem. So if the normal values in adult male, if the score is always less than 4, in adult female is less than 6, and in children is less than 3. So any score more than these, you will have to think that the patient is having bleeding, and depending on the score, you know that how severe is the bleeding. So after examination, obviously, we'll have to go for the laboratory test. So what are the screening tests for assessing any patient? These are platelet count, prothrombin time, activated partial thromboplastin time, thrombin time, and fibrinogen. You can see these 5 tests are very simple tests and can be done in any lab to assess the problem of at least initial screening of any patients who has come to you bleeding. So this is, you can see PT, EPTT, and TT. So for the purpose of discussion and for easier discussion, we will consider that intrinsic factor pathway and extrinsic pathway. So you can see this intrinsic pathway, this is represented by APTT, and extrinsic pathway, this is represented by PT. And this is the common pathway, which actually 10, 5, 2. So if there is a problem in common pathway, both PT, PTT gets deranged, and TT actually represents a defect in fibrinogen or fibrin. So if we remember that, it will be easier for us to interpret whenever the patient has come to you with the reports. Regarding platelet count, we know that normal platelet count is 1.5 to 4.5 lakhs. Thrombocytopenia by definition is less than 1.5 lakh, but for all practical purpose, if it's less than 1 lakh, then we consider it as thrombocytopenia. But one most important thing is that don't depend on the cell count report. Many a times it's falsely low. So you need to have a look on the peripheral smear, because in the cell counter, it's it's a automated programmed counter where it's a machine is programmed like that. If you consider this as particle as platelet. So sometimes the platelets are large, platelet goes into clumps. So that will not be calculated, considered by the machine. So they will give you a false report. So always we need to have a look at the smear before concluding about the final platelet count of any patient. So low platelet count or thrombocytopenia, if a patient has come to a bleeding disorder and the peripheral blood and cell count both tally with the diagnosis of thrombocytopenia, then what you are going to do? So we should know what are the causes of thrombocytopenia. So there are basically two mechanisms by which platelet count may be low. One is decreased production, where the defect is basically in the bone marrow. These are all complicated or serious hematological disorders like aplastic anemia, myelodysplastic syndrome, leukemia, drugs, nutritional deficiency, inherited bone marrow failure syndrome, or infiltration of the bone marrow by any other cancer. And it may be that bone marrow is normal, it's producing platelet in normal amount, but these platelets are getting destroyed in the peripheral blood. This may be drug-induced thrombocytopenia, immune thrombocytopenia, other autoimmune disorder, any infection, DIC, TTP, preeclampsia, HELLP. In all these conditions, it gets destroyed in the peripheral blood where the production from the bone marrow is normal. So whenever we are talking about thrombocytopenia, everybody is very much scared about platelet. Now, in fact, the dengue season is going on. Government had to give a circular that don't give platelet unless the platelet count is lower than this much. So why? Because everybody is so anxious, so afraid of low platelet count that they give platelet transfusion. But you can follow this chart. If the platelet count is 50,000 to 1.5 lakhs, there should not be any symptom. Even at 50,000, you can go for a cholecystectomy, appendicectomy for the patient. Neurosurgical procedure needs a 1 lakh platelet count. 20 to 50,000 patient will have skin bleed or mucosal bleed. 10 to 20,000, there is chance of severe bleeding from any side. And less than 10,000, it's very serious. You will have to consider it very seriously. And there is chance of intracranial hemorrhage. The representative of this less than 10,000 is wet purpura. But I told you that if there is wet purpura, you will have to take immediate action to increase the platelet count. Unless if you delay, there may be intracranial hemorrhage also. So these are the history about depending on the cause you will have to take. And one important thing is the vaccination and viral infection. And the new addition in the viral infection is COVID. Post-COVID thrombocytopenia is the important entity. All of you know by this time. And this is another COVID vaccination. And there is one entity of BITS also, which is associated with thrombosis and thrombocytopenia post-COVID vaccination. So these are the important history. We should ask the patient whenever the patient is come to us with bleeding and thrombocytopenia. This is the clinical examination to find out what could be, whether if it's a secondary one or whether there is any underlying disorder. And again, I will tell you, most important is wet purpura. We'll have to find out whether there is wet purpura or not. So these are the clinical scenario where the patient comes to us with thrombocytopenia. This I have already told you, drug-induced immune thrombocytopenia, infections and others. And this is a condition here, the patients will come as outpatient. So whenever the patient is stable with thrombocytopenia, you can consider these disorder, connective tissue disorder, infection, all these things. But whenever the patient is sick in the ICU, mostly you are not dealing with these disorders, ITP, or drug-induced and all these things. Mostly it may be either DIC or TTP, HUS, or HIT, though HIT patient present normally present with thrombosis also. So if it's ICU, the cause is different one. In a cardiac patient, thrombocytopenia is mostly because of cardiac bypass, any leading to a platelet dysfunction. It may be drug-induced, it may be heat again. And pregnancy is one important issue where many pregnant lady becomes thrombocytopenic. One important thing is gestational thrombocytopenia, which is basically a functional condition, doesn't require any intervention. But other things are ITP can first time present during pregnancy or relapse also. And these are the pregnancy related complications, help preeclampsia giving rise to thrombocytopenia. So this going back to the first case who presented with cutaneous bleed, and there is a wet purpura also. There is no organomegaly, no lymphadenopathy. So when we went for a lab investigation, we suspected this to be a case of ITP. So these are the investigation that should be advised for ITP. Regarding bone marrow, there are two guidelines. ASH guidelines said that if it's more than 60 years, you should go for a bone marrow examination. International consensus guidelines say you don't need to do bone marrow for diagnosis of ITP. So you can diagnose it at 70 years also without going for a bone marrow. These are the primary tests you should do whenever you are dealing with a suspected case of ITP. But the most important thing for the diagnosis of ITP is that everything should be normal in clinical examination other than bleeding. If the patient is having anemia, that should be accounted by the amount of bleeding. In the peripheral blood, only platelet will be low, hemoglobin, WBC, differential count, everything should be normal. And then only you can diagnose the patient as ITP. As it's in this case, everything was normal, only platelet count was low. This was 18,000 only. So these are the two things you will have to remember, that the clinical examination, no manifestations, no organomegaly, no lymphadenopathy other than bleeding, and in the peripheral blood, nothing abnormal other than low platelet count. Coming to case 3, a 4-year-old boy who presents with 2 years history of intermittent epistaxis. His birth and development history was normal, physical examination normal. His mother was very worried because last time during tonsillectomy, he bled profusely. There is no family history. Laboratory examination showed that everything is normal. CBC is normal, peripheral smear, PTT, the screening test, what I told you, are normal. So what to do with this test patient next? So type of bleeding, you can see this is epistaxis. So clinically, type of bleeding is platelet. So quantitatively, platelet count is normal. Then the next thing what we should go is for assessment of the function of the platelet. So platelet function test was done. These are the various agonists which was used, and you can see there was aggregation. The curve comes down. So this is the aggregated curve with ristocetin only, but with other agonists, there is no aggregation. So the disease was a case of Glanzmann thrombocytopenia, where there is a agglutination with risto only. There will not be any aggregation with any other agonist. So this child was diagnosed as a case of Glanzmann thrombocytopenia. Once you have suspected Glanzmann thrombocytopenia from your platelet function test, then you can go for a flow cytometry to assess the receptors, because there is a defect of 2B3A receptor. Congenitally, they are either reduced or absent on the platelet, which leads to the bleeding. This is autosomal recessive disorder. There are 3 types depending on the severity of Glanzmann thrombocytopenia. So you can see from the flow only you can diagnose whether it's type 1, type 2, or type 3, and how severe is the disease. And one important thing is that you can suspect Glanzmann thrombasthenia by a simple test by looking at the platelets in the peripheral smear. Normally, when you look at the platelet on the peripheral smear, they usually comes in clumps. But here, platelets will be present in adequate number, but these are all isolated platelets. There will not be any clump. That actually sometimes gives you a clue or suggests that maybe the patient is having Glanzmann thrombasthenia. The next case is a 30-year-old woman was admitted to the Department of Hematology for evaluation of thrombocytopenia. She had repeated mucosal bleed, epistaxis, and she was assessed, evaluated in various institutes and diagnosed as immune thrombocytopenia because of low platelet count. There is no positive family history. CBC revealed that the platelet count was 48,000 and she was having epistaxis with this count. So what is the probable diagnosis? It's not, as I showed you, that it's not expected to have bleeding at a platelet count of 40,000. So, but this patient was having bleeding at a count of 48,000. So this is not only the quantitative defect which is giving rise to the bleeding manifestation, it must be associated with some functional abnormalities. So this case was actually a Barnett-Schullier syndrome, and it's not ITP. So why it's not ITP is that patient has a history suggestive. So it started in early childhood, and patients was having bleeding manifestation at a platelet count of 48,000. So if these are present, then of course you'll have to think that whether you are really dealing with ITP or not. And this is a very common condition where most of the Barnett-Schullier actually are diagnosed as ITP, and there's a lot of steroid and complications of steroid exploded in those patients. So we are suspecting that it may not be ITP. This is BSS. But how to prove that? What we'll have to do next? So next we can go for a platelet function test, or you can assess the flow by the flow cytometry. So this is the platelet function test of that patient. The previous one, I have shown you that there was agglutination with Risto. This red color was Risto, and there was no agglutination, flat line with all other agonists. Here is the reverse one. There was agglutination with all the agonists, but there was no agglutination with Risto. So it suggests that this may be a case of BSS, but you cannot confirm that it's a case of Barnett-Schullier syndrome. It may be a case of BWD also. So whenever in platelet function test there is no agglutination with ristocetin, then you have two differential diagnoses, Barnett-Schullier syndrome and von Willebrand disease. Then how you'll come to a conclusion? Because in this patient, this was present, the platelet count was slightly lower, and this was present for a long time, and there is type of bleeding also more or less mucocutaneous. Mucocutaneous bleeding is common in BWD also. So if you do repeat the platelet function test with mixing with plasma, if it gets corrected, then that suggests von Willebrand disease. If it gets corrected with platelet, then it suggests BSS. But of course, you can go for a flow cytometry to find out whether you are dealing with BSS or not. So this is the chart which showed you how you can differentiate between BSS or BWD whenever you get a reduced or absent Risto-induced agglutination in the platelet function test. In case of BSS, platelet count will be low. In BWD, platelet count will be normal. Platelet morphologically in BSS, the platelets are giant platelets. In BWD, it's normal. APTT may be increased in BWD, but may not be. In always, you will not get this as increase. Factor 8 may be slightly on the lower side. And this is the platelet function test, which gets corrected with platelet FFP. With FFP, it's corrected in von Willebrand disease, and this gets corrected actually with platelet. So by these, you can differentiate, and of course, by flow, you can finally confirm. This is again an autosomal recessive disorder, and platelet count varies. Sometimes it may be 30,000, 20,000, and so they are diagnosed as ITP, and sometimes it may be almost normal platelet count in Barnett-Schullier syndrome. And giant platelets are one clue for diagnosis of BSS in case of thrombocytopenia with bleeding. Next case is a 57 years female. This was a type 2 diabetes mellitus and hypertension who presented with ecchymotic patches over the limbs and mild gum bleeding. There's no past history of abnormal bleeding. She underwent a cholecystectomy at 10 years back. It was uncomplicated. Peripheral blood and initial coagulation screen was normal. So this was the type of bleeding with which the patient presented to us. You can see these are all cutaneous bleed. So again, we went for a platelet function test in this patient, and this is similar to the curve is similar to that of first child who was diagnosed as a case of Glanzmann thrombosthenia. There was agglutination with histostatin, no agglutination with other agonists. So are we dealing with a case of Glanzmann thrombosthenia? This is a 57 years old lady. There was an operation, no bleed. So how it can be a condition like Glanzmann thrombosthenia? So what it can be? Then we started having a proper history about this patient. We know that this is a platelet function defect, but this platelet function defect is not a congenital one. This is an acquired one. So what is the history we should ask? We ask the patient, this patient was on drug. She was diabetic and hypertensive. She was taking clopidogrel and aspirin also. So that proves that this was a drug-induced platelet function defect. So whenever you are suspecting drug-induced platelet function defect, how you will prove that? Stop the drug for 2 weeks and repeat the platelet function test. If it becomes normal, then you know the defect was because of the drug the patient was taking. So this was a platelet function defect because of the drug clopidogrel plus aspirin, which the patient was actually taking. These are the acquired disorder of platelet function. You can see most important cause, number one cause is medication, any type of drugs, even herbal drugs. We always think that the Ayurvedic drugs are always very safe. It's not. And these are the other diseases which can give rise to a platelet function disorder. And these are the drugs which interfere with platelet function. So I think always we should have a look whether the patient is having any drug which can cause a defect in the platelet function. Whenever we get a platelet function defect, which cannot be attributed to other causes. So to come to a thrombocytopenia and platelet disorder, when we are suspecting in the peripheral smear, if the platelet count is normal and PT-PT fibrinogen coagulation screen is normal, we know that we are dealing with platelet function defect. So we'll have to go for platelet function test and von Willebrand factor assay also. If the platelet count is reduced and giant platelets are there, it may be a Barnes-Soulier syndrome. There are other symptoms also, MYH9 related disease. This is macrothrombocytopenia, which is most common in this part of the country like West Bengal, where there may be slightly lower platelet count and platelet will be larger. And if it's a reduced one, so we'll have to find out whether there is an inherited disorders of the platelet function. So this is a flow chart. Whenever you will see a defect of platelet, suspect a defect of platelet, then you can follow this flow chart to diagnose your patients. Then coming to coagulation disorder. So laboratory screening, as I told you, for a suspected coagulation disorders are prothrombin time, activated partial thromboplastin time, thrombin time, fibrinogen. So how you can come to a conclusion? Only prolonged prothrombin time. Other tests are normal. This may be because of factor 7 deficiency. This may be warfarin induced, or this may be sometimes it may be because of liver disease also. If it's an isolated prolongation of APTT only, so this is the intrinsic fact representative of the intrinsic factor pathway. So this is the intrinsic pathway factor 8, 9, 11 deficiency. Sometimes von Willebrand factor all deficiency also will give rise to slightly prolonged APTT. If both PT-APTT is prolonged, as I have told you, this is a defect in the common pathway. This is factor 5, 10, 2, and sometimes vitamin K deficiency or liver disease also will give rise a condition where bleeding will be there and both PT-APTT will be prolonged. If both PT-APTT, TT are prolonged, heparin therapy, liver disease, DIC, these are the most probable differential diagnosis. If fibrinogen is decreased along with prolonged coagulation parameters, obviously this is fibrinogen deficiency. And if everything is normal, all the coagulation parameters are normal, but the patient is having bleeding, we will have to suspect whether the patient is having factor 13 deficiency or not. So whenever clinically we are suspecting a coagulation pathway defect and we had done in the screening test, we should follow this chart to come to a conclusion and to go for further investigation. So this is the second case. As I already showed you, the child developed swelling after intramuscular injection. Here you can see this patient's PT was normal, APTT was prolonged, TT was normal, and factor 8 was less than 1%. So this is very simple case. As Dr. Kaka said, that bleeding disorder, always we think of hemophilia, but it's not. Although this patient was a case of bleeding disorder, congenital bleeding disorder, this is hemophilia A, manifested in the early phase because of trauma, because of intramuscular injection. A 13 years female presented with puberty onset menorrhagia, gum bleeding mild, no past history of abnormal bleeding. He was given oral hormone by the gynecologist and referred to rule out other medical or hematological causes. So these are the baseline investigations. Hemoglobin was low because of bleeding, PT normal, TT normal, and APTT was slightly prolonged. So menorrhagia is a primary symptom. Other than that, there was mild gum bleeding with a slightly prolonged APTT. Platelet count was normal. So in this case, again, when we went for a platelet function test, here again, there was absent Risto-induced aggregation. Aggregation was there with all other agonists. So the diagnosis was born with Librand disease. I told you that if you get this type of curve in platelet function study, that there is no agglutinated aggregation with Risto, but aggregation with other agonists. Two diagnoses: one is BSS, one is von Willebrand disease, and I showed you how to differentiate between BSS, Barnard-Schulze syndrome, and von Willebrand disease. A 32-year-old woman was referred for intermittent epistaxis for a few years. She had easy bruising, but no menorrhagia, no childhood bleeding, no family history. She progressed to have few episodes of hematuria, which was treated as chronic cystitis. So this was basically intermittent epistaxis with which the patient has presented. Platelet count was 88,000. The previous patient presented with a count of 48,000 with bleeding. Here the patient has presented with 88,000 with bleeding. Coagulation parameters were normal. So obviously it's not because of thrombocytopenia, it's because of associated platelet function defect. So again, we went for a platelet function test. Here you can see everything is normal. So you can say that platelet function test is normal. I agree. From this chart, platelet function test is normal. So then what we do a test with low dose ristocetin. You can see there is no curve with low dose, but with low dose Risto, there is a curve. So this is a condition what we call von Willebrand disease type 2B, where platelets are low, thrombocytopenia will be there, and these actually platelets are very sensitive. So with the abnormal von Willebrand factor, and it causes aggregation with low dose ristocetin. So these platelet count, some consumption is there. The spontaneous coagulation platelet consumption is there because of high affinity of this von Willebrand factor for platelet. So platelet are slightly lower, and the platelet function test also is abnormal. So this is the type of von Willebrand disease. Here only type 1 and type 3 are quantitative defect. Type 1 is a mild type quantitative defect, presents only with either menorrhagia, gum bleeding, as I have showed you in the case. Type 3 is a severe type. Patient is almost like a case of hemophilia, and factor it almost you will not get in the blood, so often confused with the hemophilia. And type 2, all are functional defect. The multima varies, and these are the picture by which you can differentiate whether the patient, first of all, quantitative, you can differentiate easily whether 1 and 3, whether 1 or 3, and if it's not quantitative, then you will have to come to this. Out of this, 2B is the most common one, others are not that common. 33 years female presented with headache, vomiting, convulsion, history of 3 spontaneous hemorrhagic miscarriage, not diabetic, non-hypertensive. Patient has prolonged bleeding after injury. There is history of delayed wound healing. and coagulation profile and platelet count was normal. So here you have two clues. One is a CNS bleed, second is a delayed wound healing. So this is a case, this is a CT scan of that patient which shows that the intracranial bleed is there. So we did a platelet function test again because everything is normal. Platelet count normal, coagulation initial screen is normal. But in this case, we didn't get anything. Platelet function test was normal. Then we went for a clot solubility test that was abnormal. So factor 13, actually, if there is a factor 13 deficiency, we will get abnormal clot solubility. We sent for a factor 13 level, and factor 13 level was 3% only. So this was a congenital factor 13 deficiency. Congenital factor 13 deficiency is a rare inherited autosomal recessive disorder. Main features of congenital 13 deficiency, they're very prone to get intracranial hemorrhage. There may be impaired wound healing, recurrent pregnancy losses, and sometimes the mother will give that there was history of bleeding from the umbilical stop. So if these are present, so we can think clinically that whether we are dealing with a case of factor 13 deficiency. If you diagnose that in a female like that patient, they actually should be on prophylactic factor 13 that we can give from cryoprecipitate, which is a rich source of factor 13. Coming to the last case, this is a 10-month-old child referred to hematology with history of ecchymosis. You can see the ecchymotic patches here. These are the ecchymotic patches. No active bleeding, no family history, nothing else is there. Platelet count was normal. PT was prolonged. APTT also was slightly prolonged. TT was normal. So this is PT, APTT prolonged. I told you before that if PT, APTT both are prolonged, then the defect is in the common pathway. So this common pathway are 10, 5, but here in another condition you can have both PT, APTT prolonged. This is sometimes we get a combination of factor 5 and factor 8 deficiencies, because of factor 5 this PT also becomes prolonged, and factor 8 obviously will give rise to APTT prolonged. So whenever we will get a patient with both PT, APTT prolonged, and if it's in a small child where it's suspected to be a congenital one, then of course these three are the differential diagnosis, and we'll have to go for the factor assay accordingly. Otherwise, this is a study which was used to be done in all the labs before, but nowadays very few labs are doing this mixing study. Whenever we get a prolonged coagulation report, prolonged APTT or PT, we correct it first with normal plasma. If it gets corrected, then we know this is a functional deficiency, not inhibitor. If it doesn't get, if it gets corrected, so this functional deficiency, we'll have to find out, like in this case, whether it's 10 or 5 or 5-8. So if it gets corrected with serum, then it's factor 10 deficiency. If it gets corrected with plasma, it will be factor 5 deficiency. So this patient, it got corrected with aged serum only. So this was a case of factor 10 deficiency. Further confirmation is to be done by the factor assay. So factor 10 deficiency usually present in the infancy with cutaneous bleed all over the body, and PT, APTT will be prolonged in those cases. Sorry, that was not the last case. So this is a 26-year-old female diagnosed as SLE. This was a case of SLE who actually was having ecchymosis in the right lower extremity and some spots over the body also. She was taking, when she presented to us, she was taking prednisolone and pantoprazole only for SLE. Physical examination was normal because except those hematoma and ecchymotic spots. Platelet count was normal, PT is normal, APTT was prolonged. So this is a patient of SLE with prolonged APTT. So what are the possibility? We told that prolonged APTT causes, but here this is a adult patient, adult onset of bleeding manifestation with underlying immune disorder and prolonged APTT. So this is an acquired defect and intrinsic pathway defect. So this case, if we went for a coagulation for correction of the APTT also, it didn't get correct. So if it doesn't get corrected, then it is because of inhibitor. So this is a female with SLE. So it's not hemophilia. So hemophilia with inhibitor is not applicable here. So this is an acquired inhibitor for factor 8. So how we'll confirm? So as I told you, the mixing study, it didn't get corrected. And even 2 hours, it was prolonged initially also after 2 hours. Also factor 8 level was very low because the antibody was against factor 8. And we went for to assess the, like quantify the inhibitors. Here the inhibitor quantity was very high. This was 61 Bethesda unit. So in a SLE patient, antibodies against factor 8, which was very high with 61 Bethesda unit, giving rise to various clinical manifestations of bleeding. So this is acquired hemophilia. So acquired hemophilia can be there in female also or male also, whether congenital is X-linked. Commonly, it's associated with immune disorder, as it's in this case of SLE. It may sometimes be found with associated with hematological malignancies like CLL, lymphoma, myeloma, MDS, and solid tumors also, CA breast, lung, stomach, pancreas. If they come with a bleeding manifestation and the lab picture is like that, of course, it's a diagnosis is acquired hemophilia. And pregnancy is one condition when basically it occurs in postpartum period where the patient comes with bleeding manifestations, prolonged APTT, and we can diagnose a case of factor 8 inhibitor. So these are the conditions when you can get acquired hemophilia. So diagnosis is not the end of anything. Whenever you have diagnosed the patient, of course, you'll have to give some remedies to your patient who has come to you with bleeding manifestation. So this talk was on approach to bleeding. So I'll just touch how actually we should manage this patient. A basic outline, not specific treatment of all disorder. Most common disease what we see with bleeding disorder is ITP. So as per recent guideline, first line of drug is either IVIG, especially in children is IVIG. In adult, you can go for steroid also. You can go for anti-D. If you want to go for anti-D, then patient's hemoglobin should be more than 10 gram. Patient should be Rh positive and that should be negative. And patient should not be a splenectomized one. Then only you can go for anti-D. Second line drug has changed. Previously, we have a lot of drugs, danazol, dapsone, azathioprine. In the recent guideline, everything has been removed. Though in a country like India, the significance of those drugs are still there. But as per guideline, first choice is thrombopoietin receptor agonist. Most of the cases of chronic ITP, now this is the drug of choice. Then second line is rituximab. Splenectomy is lowered down, but it's not out. It's a last choice. If the patient is refractory to everything, then only you can go for splenectomy. So trigger for platelet transfusion, I told you, if the patient's platelet count is 10,000, other than ITP platelet transfusion is not indicated. Then for any patient, you should give platelet transfusion. If the patient's platelet count is less than 20,000 and the patient is having fever, sepsis, or patient is on drugs like amphotericin, you will have to go for prophylactic platelet transfusion, even the patient is not bleeding. If you are going for surgery and the platelet count is less than 50, if you are going to give a epidural anesthesia, platelet count is less than 80,000, you should go for a platelet transfusion. For neurosurgery, if the platelet count is less than 1 lakh. For any platelet count, if the patient is having bleeding manifestation and if you think that the bleeding is because of platelet count, you will have to give platelet transfusion. So most important is that for other normal patient, platelet transfusion is not required unless the platelet count is less than 10,000. So two types of platelets are available. One is random donor platelet, what actually we get from the blood bank. Another one is STP or single donor platelet. This is collected from a single person and this is equivalent to 6 bag of random donor platelet. Here the advantage is that chance of aluminization is less because the patient is exposed to one donor only, where the patient is exposed to 6 donors whenever we are giving RDP. For coagulation disorder, if we don't know the exact diagnosis, but we know that this is a case of coagulation disorder, suppose the patient is having bleeding manifestations, coagulation parameters are deranged, PTA, PTT is prolonged, but you don't know till that time, you have not diagnosed. So the therapy of choice should be FFP, because FFP contains all the coagulation factor. So you can control the bleeding with FFP when it's coagulation disorder, but you don't know the specific diagnosis. Any factor deficiency, whether you don't know, and factor concentrate is not available, you know the deficiency, it's hemophilia A or B. If factor 8, 9 is not available, you can give FFP. Factor 13 deficiency or fibrinogen deficiency, you should go for cryoprecipitate, because this is very rich in factor 13 and fibrinogen. Regarding plasma transfusion, a few important points is that it's given in coagulation factor deficiency, DIC, and whenever the patient is having bleeding because of excess dose of warfarin, dilution and coagulopathy, that is after massive transfusion, hemorrhagic liver disease, and in cases of TTP, thrombotic thrombocytopenic purpura. This is the fresh frozen plasma. Dose is 15 ml per kg, but plasma should be ABO compatible. For platelet transfusion, preferably it's ABO compatible, but you can go for other group platelet if the platelet of that specific group is not available. But FFP should always be ABO compatible, because it contains lot of antibodies and the volume is large one. So the take home is that whenever a patient has come to you with a bleeding manifestation, a detailed history and clinical examination is of great importance. I think the most important thing is a history and clinical examination, from which you will have to decide whether you are dealing with a platelet type of defect or coagulation defect. Then you'll have to decide whether it's a congenital defect or acquired one. Baseline screening test, as I told you, platelet count, peripheral smear examination, PTA, PTT, and fibrinogen. Subsequent investigation will depend on the result of the screening test, but the result must be interpreted in the background of the clinical information, because the same test I have shown you, the same type of platelet function defect diagnosis may be different in two patients. So the clinical background is very important, and all the results should be interpreted in the background of the clinical information. And if your patient is having bleeding manifestation and normal initial screen, of course, you'll have to think either platelet function defect or factor 13 deficiency. And whenever you are giving a treatment to your patient, judicious use of platelet concentrate and FFP should be given for management of any bleeding patient till you diagnose and go for a specific therapy. Thank you for your patience hearing.
Thank you so much, ma'am, for that wonderful and superb and fabulous lecture. You have always been a wonderful teacher, a great teacher, always. And many students have benefited a lot from your mentorship and have been a successful hematologist under your mentorship. Thank you so much for being with us today. And with a wonderful lecture, we will start with our question answer session with you. And for that, I now request all our discussants to please put the raise hand side so that we can start our question answer session with Professor Dr. Maitri Bhattacharya. Dr. Ganju, sir?
Yeah.
Your question, please. We cannot hear you, sir. Can you please be loud? You're muted, sir.
Yeah, can you hear me now?
Yeah, now we can hear you. Yes, ma'am. Yes,
Yeah,
sir.
that was great lecture by Dr. Mistry. So, excellent, these reports which he actually documented and delivered here. That made something very clear. Now, my one question which I want to ask, can you hear me now?
We can hear you, but it's a bit
That's
disturbance in
not
your voice.
clear.
It's not clear, sir. Can you please be louder, sir?
Yeah.
Yeah.
My question is, I have a patient who is hemophilic. His age is 60 years, and he developed coronary artery disease, for which he had to undergo angioplasty. So, how do we manage this patient who has hemophilia and now coronary artery disease, for which he requires antiplatelet drugs?
Dr.
Ma'am,
Amit, can you repeat?
Yeah, patient has got hemophilia and patient has got a coronary artery disease posted for angioplasty. How would you go about this, ma'am? When the patient has got hemophilia and patient has got coronary artery disease now posted for angioplasty. Am I right, sir? That is
Yeah.
the question? Yeah. Yes. Yes.
Yeah,
ma'am.
so you can go for angioplasty. You'll have to go actually for angioplasty because it's a life-saving procedure. So this procedure, you'll have to give a adequate amount of factor 8 before the process to secure the hemostasis. And with that, you can go for coronary angioplasty for this patient. Like any surgery in a hemophilia patient can be done, orthopedic surgery, cardiac surgery, neurosurgery, but adequate amount of factor replacement for definitive period should be given to prevent bleeding.
Problem here to be all chronic aspirin and clopidogrel. So do we need to continue with the factor VIII replacement for a prolonged period of time?
The sir is asking, ma'am, that cardiologists put the patient on aspirin and clopidogrel after the surgery. Do they require aspirin clopidogrel after the surgery? Do we need to continue with the same in the patient of hemophilia?
Yeah. This is a very important question because this is a double-edged sword because clopidogrel or aspirin is going to give rise to bleeding manifestation. But if you put the patient on prophylaxis for hemophilia, then you can give the patient preferably single antiplatelet drug to the patient. But if it's required that it's not sufficient, then of course we will have to go for dual platelet antagonist, but we'll have to keep a close watch for bleeding, and a regular high dose prophylaxis should be given for hemophilia.
Any other questions, sir?
Similar case in patient of. Can I ask one more?
Yes, sir. Please go ahead. You have to be a little bit louder, sir, because we cannot. There are some disturbances. Yeah, please go ahead, sir.
The patient who is 23-year-old has developed EPLA. He has lupus positive, anti-coagulation and anti-phospholipid antibody positive with low platelet counts, and he has deep vein thrombosis. So how do we go about it? So a patient with DVT, EPLA, and extremely low platelet counts.
So, ma'am, patient is thrombocytopenic, EPLA positive, lupus anticoagulant positive with deep vein thrombosis. How would you go about this, ma'am? With profound thrombocytopenia and deep vein thrombosis.
Like we face this condition many a times, not only in cases of EPLA, like our leukemia patients sometimes develop thrombosis. This may be catheter related, this may be because of dysfibrinogenemia, platelet count is low because of disease, because of the treatment. So thrombosis and thrombocytopenia. So you need to give anticoagulant and platelet count is low. If we'll have to maintain a platelet count around 40 to 50,000, and on this count, you can go for anticoagulant for your patient, what anticoagulant the patient will require. But in case of lupus anticoagulant, duoxetine till death is not recommended. Either you will have to go for low molecular weight heparin, or with proper monitoring warfarin you will have to get.
Thank you. Any other questions, sir? Any other questions? Thank you so much, sir. Dr. Avinash Singh, your question, please.
Yes, thank you. And excellent talk, Maitri ma'am. So my question is for patients who are having mildly low factor rate, like 8%. So should we always rule out VWD in that case? How to approach low factor rate, like 8% or 10%?
Yeah, like depending on the bleeding manifestation, suppose low factor 8, level 8, 10%, if it's a female, if menorrhagia, gum bleeding are the clinical manifestation. I told in my last slide that all the results of investigation should be interpreted in the clinical background. So if these things are present, then of course we know that we are not dealing with a mild factor 8 deficiency, but we are dealing with a von Willebrand disease. In all that cases, we'll have to go for von Willebrand disease. But in a male child who was brought to you because of bleeding after trauma and factor 8 level is 10%, 8%, in that case more, and if the bleeding is in the musculocutaneous type, joint type, then of course musculoskeletal bleeding, you can think that you are dealing with a factor 8, mild factor 8 deficiency. This bleeding is because of trauma. Then you will not go for von Willebrand factor acid.
Thank you, madam. And I have another question. So just similar to one question that was asked one lady who is having afibrinogenemia. She was on fibrinogen concentrate prophylaxis because she used to bleed hematuria and other things. And suddenly she developed large infarct, CVA. So the neurophysician, they were of opinion that we should add antiplatelets. So how to manage this type of patients? So always it's difficult when there is bleeding risk as well as when there is large infarct. So she was continuing with fibrinogen concentrate, but how to manage the this one antiplatelet? What?
Because a thrombus is like I don't know whether it's dysfibrinogenemia with hypo or it's a fibrinogenemia, because most commonly all the dysfibrinogenemia patient, they are prone to get thrombosis at the same time. So it may be a case of dysfibrinogenemia also, most like more chance, or it may be fibrinogenemia also. But if the patient develop a CNS bleed, and in that case, if the patient requests, again the same thing, if it's life-saving, you'll have to go for that and taking care of the fibrinogen defect. And even if a surgical intervention is required for the life of the patient, you'll have to go that with proper supplementation of the fibrinogen. And nowadays, a commercially available fibrinogen is also there. So the process has become easier nowadays.
Okay, thank you, madam. And can I ask another question? Last question.
Please go ahead.
Yeah,
Please
Yes.
go ahead.
Yes. So in your experience for refractory ITP, have you used ATRA or 6-MP or cyclosporine in some patients who are very difficult to treat? They have not responded to anything and they are bleeding. So any experience with this one, ATRA, 6-MP or cyclosporine in refractory ITP?
Yeah. Some of the patients, they don't respond to the standard guideline drugs. So I've seen one important drug and very good drug is this thing, Dapsone, to which many patient responds to Dapsone also. Second is that cyclosporine. Cyclosporine, I have experienced that refractory ITP sometimes respond to cyclosporine. 6-MP I have never given. Danazol also is a good drug in case of, so as I told you, these drugs are very important in a country like India. In some of the refractory cases, you can try these drugs like Danazol, Dapsone, azathioprine, cyclosporine also. Cyclosporine, in a few patient response was very good with cyclosporine also.
Thank
But
you, madam.
6-MP I have never given, Avinash.
Yes. Thank you, madam. Thank you.
Thank you, Dr. Avinash. Dr. Avinash, to just add and comment on this note of your ATRA, in the last meeting when the MSG webinar took place on the refractory ITP by Dr. Priyanka Chauhan, a question was raised regarding the use of ATRA. And there were two wonderful articles which came in the year 2022 December regarding the use of ATRA plus danazol and ATRA plus low-dose rituximab. But what MB Agarwal sir has commented that nothing great is happening with ATRA in the research which was done by Dr. Brussel and Dr. Cotter in USA. So right now it is just in the phase 2 panel with 65% response rate, which is shown as a phase 2, but yet the data is still needed whether to use ATRA officially in the clinical care of the patient.
Yeah, I agree with Dr. Amit that ATRA with rituximab, ATRA with steroid, ATRA with danazol, various combination studies are going on, but I have never given. One of my student, and he's under another faculty, Dr. S.S. Rai, he is doing a thesis on ATRA plus steroid combination as frontline therapy in ITP, but till now it's going on. So I personally don't have any experience with ATRA.
Okay. Thank you, madam. Thank you, Dr. Amit.
Thank you, ma'am. Thank you, Dr. Avinash, sir. Dr. Kunal, your question, please.
Good afternoon, ma'am. Thank you for the excellent lecture, ma'am. Ma'am, I have two questions. First is a 57-year female who is having a myelofibrosis and history of portal vein thrombosis in last 6 months, and now she is having platelet dysfunctions in the form of aggregation. How to proceed, ma'am?
Myelofibrosis patient with portal vein thrombosis and
Yes,
a
ma'am.
platelet function defect again.
Yes,
So
recently
the patient was.
platelet.
So this is a spontaneous platelet function defect. Yeah, the patient was having any bleeding manifestations?
Yes, ma'am. In the forms of occasional petechiae purpura and some hematomas, ma'am.
So, portal vein thrombosis, if it's a severe one, and if it severe features of portal hypertension and requires anticoagulation, because this most likely is a JAK2 positive myelofibrosis. In that case, you can go for therapy, but looking at the again, you will have to monitor the patient closely for bleeding because of the underlying platelet function defect. And what I think is that if you treat myelofibrosis, then the underlying platelet function defect can be reversed. Okay, so we'll have to take care of that also. This is because of the underlying disease only, secondary platelet function defect. And what type of platelet function defect was there?
Aggregation defect, ma'am.
Like this is a specific defect, like with Risto, with aspirin,
No, ma'am.
arachidonic acid.
Risto, ma'am. With Risto, there is some response.
So in that case, what I think, if the patient is having active bleeding, then of course you can't go for a anticoagulant. If the patient is not having active bleeding, only occasional spots, then you can go for a anticoagulant.
Okay, ma'am. At present, she is on monitoring, and on and off bleeding is there, and which resolves.
If bleeding is there, then you can't go to the anticoagulant.
Yes. Ma'am, second question is in your lecture, ma'am, acquired factor 8 inhibitor, how to manage, ma'am, these patients, ma'am, with higher Bethesda level?
First line drug is endoxan and steroid. And if the patient doesn't respond, then you can go for rituximab also.
Okay,
Cyclophosphamide and steroid combination is the first line drug.
Thank you.
This is because inhibitors are immune inhibitor. It's a acquired inhibitor. So you'll have to give some sort of immunosuppressant.
Okay. Thank you.
Thank you, Dr. Kunal. Dr. Siddesh Kalantri, your question, please.
Good afternoon, ma'am. Very nice lecture. Ma'am, there are certain scenarios where in OPD we have middle-aged female who has got occasional petechial or ecchymotics rashes, and everything is normal. Like you do platelet function test, you do platelet count, you do PT, APTT, fibrinogen, drug history, no herbal products. So in these scenarios, what do we tell patients? And we do other acquired causes also. We look at B12, we look at thyroid function, and everything comes normal. And even paraproteinemia screen is normal. So in these scenarios, and some history of mild heavy menstrual bleed, maybe 6-7 days passage of clots and nothing else. So like what do we tell in these scenarios, or do we
I
order
fully
molecular
agree
test?
with Dr. Shiddesh that 5 to 10% cases with the standard investigation procedures, we will not be able to diagnose. And all these cases, whatever cases have come across, are mild cases. Like as you said, occasional, most of the times they come with occasional ecchymotic patches, or maybe a mild menorrhagia also, and everything is normal in these cases. So 2-3 things are there. One test is the thromboelastogram, which is not actually recommended for routine practice, but this gives some idea. This is actually for transplantation point of care investigations. This can give you one idea whether it's a platelet defect or a fibrinogen defect or a coagulation defect. First of all is that. Second is that sometimes nowadays papers are coming that you can go for if you are suspecting this is a congenital one, you can go for a NGS also to find out whether the patient is having a rare type of bleeding disorder. There are many rare bleeding disorder which will not be covered by the standard investigation. But most of the time, if you ask me what I do, I just counsel the patient that nothing to worry about, and you don't have any serious type of bleeding disorder, so you don't need any further treatment also. Because NGS, we are not so familiar. It's very easy to do NGS. It's very difficult to interpret NGS. So I'll request all of you to be very cautious for NGS.
Thank you. Thank you, Dr. Siddesh. Any other question you have, Dr. Siddesh?
Thank you, ma'am. Thank you.
Okay. Dr. Nishad, just be ready with your question. I will take 1 or 2 questions from the audience. Dr. Pritesh Junagade wants to know what is the dose of rituximab to be used for chronic ITP patients?
It's all of you know you can go for a low dose rituximab weekly for 4 weeks, and or even you can give the standard dose of 375 also. Result is almost same, but that's they say the duration of CR is more with the higher dose. Duration of CR may be less with the lower dose, but you can go for the low dose also.
So, ma'am, thank you so much, ma'am. Dr. Neha Ganju wants to know where is factor 13 assay available in India commercially?
Yeah, it's available. Even in Kolkata, it's available.
So, Dr. Neha, that is the answer. I think everywhere it is available, and you can do it in Kolkata also, as well as it is also available in Mumbai also. Dr. Nishat, your question, please.
Ma'am, Dr. Nishad here from HCG Nagpur. That was an excellent lecture. I want to know tests like platelet function assays are not available in every 2-tier cities like Nagpur. So, is it that we always have to send send the patient to a center who is performing the test, or is there a way out that the sample can be transported?
No, for platelet function test is to be done within 2 to 3 hours of collection of the sample and making a platelet-rich plasma. So you cannot send the sample to a distant place. Like if it takes half an hour, then of course you can send them. But there also the lab, most of the labs, they don't accept samples like that. There are so many things that they need to maintain whenever they are doing a platelet function test. So it's better that you should send the patient. And in these contexts, I want to tell one thing, that coagulation assay should not be sent to a distant place. Many a times factor assay is sent to Mumbai from Kolkata, or a coagulation factor also sent to Delhi. So because you know these tests should be done within a specified period of time. This sample will reach there after 24 hours, test will be done after 48 hours. Then the result obviously will not be erroneous. So it's better always to send the patient there, except for the molecular assay. If you want to know the mutation of hemophilia, of course, you can send the patient sample to a distant lab.
Okay, thank you, ma'am.
Thank you, Dr. Nisha. Dr. Ganju, sir, you have another question? Yes, sir. Do you have another question, Dr. Ganju, sir? Okay. So I've finished all the questions from the chat box. Any discussants want to ask any question to Dr. Maitri, ma'am? Fine. So if there are no questions from the discussants, and I've finished all the questions from the chat box. Well, ma'am, thank you so much for being with us today. What a wonderful lecture. What an approach to bleeding disorders. Always good to hear to you. You're a fabulous teacher, fantastic teacher, excellent teacher.
Thank you, Dr. Amit. Thanks a lot.
And what a wonderful discussion, ma'am. Thank you for being with us today on this Sunday morning. Thanks a lot, ma'am. I now hand over to Zydus for the final vote of thanks.
Thank you, ma'am, for the excellent talk. It was a great learning session for us. Thank you, Dr. Amit, sir, for letting us be a part of this discussion. Thank you, everyone.
Thank you.